Welcome to Beyond the Data. I'm Dr. Phoebe Thorpe, and here with me today is Dr. Larry Garber from Reliant Medical Group. Thank you so much for joining us.
Thank you for having me.
The session today is about medication adherence for chronic diseases. Why is this a problem, having patients not being able to take their medication when they're prescribed it?
It's actually, I've been a physician for 30 years, and it actually came as a surprise to me. For many years, I just assumed that patients were taking their medications and would just wonder why some people's blood pressure wouldn't improve or their cholesterol wouldn't improve with the medicines, until I started to learn and understand that for patients on chronic medications, half of them are not taking the medications as prescribed. They're not adhering to their regimens. And so it's a huge problem. And there are many reasons, but the implications are phenomenal. That it impacts the health of our patients, that they're more likely to progress to problems and disability related to their diseases, or even to death. And besides being obviously bad for our patients, it's also bad for society. It costs hundreds of billions of dollars every year that are wasted on hospitalizations or support for the disabled patients who have suffered diseases because they haven't been adhering to their medications. And
you said there were lots of reasons that patients don't take their medications. What are some of them that you found out?
I guess the way I've looked at it is they fall into two categories. The categories of patients intentionally not taking their medications and sometimes unintentionally. So for intentional reasons, often more and more it's becoming due to the cost of medications. They're very expensive, and if they can't afford them, if they decide, do I eat or do I take my medicines, they choose to eat. So cost is a reason, and also a lot of times they don't like the side effects that they're getting from the medications, so they'll choose not to take them because of that. And a lot of times they also don't believe that they ought to be taking the medications. They don't believe that the medications will work for them, or someone's told them, oh, you shouldn't be on that medication, or maybe there are cultural reasons that they believe the medication's not good for them, and so they don't take it. And then there are a lot of unintentional reasons why patients don't take their medications. Sometimes they forget. We're all human. We forget to, I have trouble remembering to take medicines when I'm on them as well. But also, sometimes it's just that they don't realize that they were actually supposed to take that pill every single day, or to continue to take it when that bottle, was done and they had to get a refill. And there are other also unintentional reasons. If their medication regimen is complex, that they're supposed to be taking pills multiple times a day and different pill combinations, they may accidentally not take the medications. And then sometimes due to other illnesses that they also have, maybe they have problems with dementia, they're confused, so they may not be able to remember or know that they're supposed to take their medications. Or maybe they have visual problems, they may not be able to see how much insulin they're pulling into their syringe to be able to properly give the administration. Or maybe they have arthritis in their hands, so they can't open their bottles, or they can't split the pills. So there are lots of different reasons, and it's typically not just one. It's usually a combination of reasons that reach to the point where a patient just won't follow their medication regimen.
And in the session today, your group has done a lot of interesting things. Kind of some are very practical, but some are high tech, helping clinicians do a better job of making sure that their patients take the medicine. Can you tell us about some of those?
Sure. The way I look at it, and the way we've looked at this problem at Reliant Medical Group, is that if you want to change someone's behavior and if you want them to do something, you really have to satisfy what I call 3 pillars of success. And these apply to whether you're trying to get someone to take their medications, whether you're trying to get a physician to use an electronic health record, whether you're trying to get your spouse to take out the garbage. It's the exact same 3 things that you have to pay attention to. So first is you have to make sure that there's value. Patients have to recognize the value in taking their medications. You have to educate them to understand why not taking the medication and letting their disease progress is a bad thing, and that taking the medication, has the benefits of controlling the disease, reducing the progression, reducing the chance of developing problems related to the disease. So that value is important. In fact, even myself as a physician, I need to find value in that relationship. I have to recognize that it's important for me to encourage my patients to adhere to their medications. So everybody has to see value in this. The second thing is that it has to be convenient. So it really has to be convenient for the patients to take their medications. So that's, as I talked about, making sure they can afford it, but also that the regimen is simple. They should take once a day medications so that it's a simple regimen that they can do. Patients are people too, and they have busy lives, and it has to fit into. So you want to give them pill boxes that have the medications laid out for the week, so that it's easy for them to remember. Did I take the pills? And have them located in a place that's convenient for them to remember when they're brushing their teeth. Oh, I need to take my pills. There's the pill box. So you really need to get it to fit into their lifestyle. And we've done those kinds of things. Also, you want patients to be able to monitor the effect of their medicines to show that they actually do work. So one of the things we've done at Reliant is we've given patients home blood pressure monitors. So for hypertensive patients, they can take readings, and just plugging it in the monitor into a computer, it uploads the readings into our electronic medical record. So they don't have to get on the phone and call and give us our results, and they don't have to come to a visit to give us their blood pressure readings. They can just do it simply by plugging it in, so it's convenient for them. So that's the second thing. And then the third thing is trust. You really need to develop a trusting relationship with patients. They need to believe everything you say, that it's important. And trust is interesting because the Gallup poll has done studies every single year. They do surveys to find out who do people trust. And it turns out people trust nurses more than they do trust doctors and pharmacists. Year after year, nurses top the list of people that you trust. So you really need to leverage that and actually get nurses to be part of the team to continue to reinforce that message about how it's important to take these medications, to adhere to the regimen that they're supposed to be taking them. So that's really important. I call these the 3 U's. It has to be useful, usable, and you have to develop trust.
Okay. Oh, yeah. That's what. Yeah. So some of what you've talked about is more on an outpatient side. What about inpatient and hospital-based physicians and care teams? What can they do?
Well, that's so important because these days, when I started practicing medicine, I was the outpatient doctor and I was the inpatient doctor. I took care of all my patients in the hospital. But now, most of the time, it's a different team of physicians and staff that are caring for the patient in the hospital than the team that will see them in follow-up. And so what can happen is there's this tendency to just hand off the patient, to that follow-up team, the primary care physician or referring physician, and think that it's their responsibility to take care of the patient after that. Whereas what as you heard today, is that if you actually have the inpatient team focus on making sure that the handoff is successful and that it's not fumbled, they can make sure that the education to the patient takes place completely and thoroughly at the time of discharge, and then contact the patient after discharge to make sure that they got the pills that they were supposed to be taking and that they know what they're for and that they're taking them correctly, that proper handoff and the follow-through can really make a difference in medication adherence and reducing adverse events, reducing rehospitalizations, things like that.
Yeah, was a very interesting point from today's session for me about how that follow-up really did make a difference. Right. The other thing that I wondered about, or I just at the bottom of it all, it really seems like it's the kind of the patient's responsibility in the end to take these. They're the decision maker. What would you suggest patients and people do to about taking medications? What's their role in it? Well,
it's both the patient's role as well as the physician and provider team's role to work together. I may have made it sound like it's the doctor decreeing, you're going to take these pills, here you go, good luck with it. But it actually needs to be a discussion. Mm-hmm. It needs to be a two-way negotiation to understand, what are the best treatments for a particular problem, and if it is medications, what are the most appropriate medications. We really need to understand what are the actual personal situations that the patient is in. Do they have financial issues? Do they work the night shift so that the timing is not in the morning, it's when they wake up, which is different? Do they have problems with opening pills or transportation, or these social issues really need to be conveyed and discussed between the patient and the physician. So